Welcome to the webinar Comprehensive Review of Possible Complications with Implant Restorative Procedures. It is a lecture being presented by James Wayne Leonard, DMD, and we're going to begin shortly. And with that, it is my distinct honor to introduce James Wayne Leonard, DMD. He is the Vice President of Clinical Services at the North American Dental Group. Dr. Leonard has more than 25 years of clinical, educational, and operational experience, to include the NDX Board for Continuing Education. As the VP of Clinical Services for North American Dental Group, he mentors doctors, evaluates practice operations, provides clinical insights, and contributes to the educational programs. Dr. Leonard has presented extensively on restorative scanning, implant restoration, and leadership principles. He has completed the Implant Educators Mini Residency Program and is a fellow in the International Congress of Oral Implantology. And tonight he joins us to present the following course. Take it away, Dr. Leonard.
Wow, Jessica, I think that was harder than the presentation I'm going to do. That was a very, I almost think you did that from memory based on getting to know you. So, but as Jessica said, my name is Wayne Leonard. And, I've been in practice for about 26, 27 years, been at this for quite some time. I actually don't practice as much these days as I used to. And when Jessica asked me if I could present something, for the NDX team, I was like, well, I don't really know, what could I present that would have an impact, do some leadership things. He's like, well, we really need something clinical. And I really got to thinking back, in my career, when I was a lot more active, just 6 months ago, that implant failures and things that you run across in your office with implants are an area that, I spent a lot of time with, and I would have a lot of patients come to me and say, hey, can you fix this implant for me? And so I'm very excited tonight to present complications with implant dentistry. It's going to be an interesting presentation. I like it because it's kind of low pressure for me. We're going to talk for about an hour. A friend of mine told me the other day when they go to a course, they are looking for 1 to 2 nuggets of information. And I said, well, how long do you go to the course? And they were like, well, they're usually 2 days. And I'm like, well, wow. So in an hour, I don't even have to teach you a single thing. And I'm still well within the range of what a normal course would be. But I'm going to try to show you a few things. I actually don't even know for some of you if I'm going to show you anything particularly new, but I want to help bring some things to your attention and kind of spend some time really thinking about why implants fail. So the first question I got to thinking about is, why would we want to take on restorative implant issues, especially as general dentists? I mean, we can easily refer these to prosthodontists. We can kind of kick it to someone else, say, hey, this wasn't my implant. I didn't do it. I don't want to take it on. But I think when you really start to dig into implant restorative dentistry and you become a dentist who will take on complications, you really start to understand restorative implant dentistry better. Because it really kind of challenges you. So, implant dentistry to me is really about engineering and mechanics. And a lot of times on the front end with our restorations, we don't really think about engineering and mechanics. We think about teeth, and we think about what teeth normally do. But when we go to correct a complication, we have to really think about what implants do. So I think when you start actually taking on complications, it's going to make your implant dentistry itself a lot better, because you're going to restore your implants in a way where you're trying to prevent the complications in the first place. It's very convenient for our patients. It can save them a lot of extra time and cost, especially time. We tend to think in terms of cost, but the reality is it can save a lot of time. For some of the things that we're going to talk about tonight, if you can save a trip to the prosthodontist, you can save time away from work, time away from family, and it actually puts probably you in a better position to help the patient in the first place, because I will tell you, you have a lot of leeway with implant complications with patients, because most patients, when their implant has a problem, they automatically think that it failed. And so I can't tell you how many times I've had patients, maybe crown, implant, the whole thing become loose, and they think the implant is destroyed or it's not going to work. And when I tell them, hey, the implant is fine, we just have to correct the restoration. I mean, their attitude and their approach to the procedure completely changes, because the biggest fear for patients is that the implant is destroyed. Unfortunately for us, most of the time it's not the implant, it's the implant parts. And we'll talk about that a little bit later, like why is it typically the implant parts, which is really good news for the patient, but typically good news for us as well. The procedures are generally not as difficult as they may seem. If there's a fragment, a broken screw in an implant, it can look intimidating, but when you really start to explore and think about it and get the right tools, it's actually a very straightforward procedure to complete. It can lead to referrals and a reputation as advanced restorative implant dentist. Really, over time, if you take on these types of situations, you help patients through their implant problems. They will go into the community and say, hey, this, Dr. Leonard, Dr. whoever it may be, they helped me out of this situation. You should go see them for your implant work. So usually when you help these types of patients, they tell a lot of people because they've already told a lot of people that there's a problem, because it's a scary thing for them. And they naturally will say, well, this is the dentist who fixed it for me. And then it really provides a feeling of accomplishment, and there's gratitude from the patient. So some of these things, the first time you do it, it's going to feel like you discovered fire. I mean, it is some of the funnest dentistry to do when you actually solve something that, is difficult, or that a lot of other dentists may not be willing to take on. So let's talk about really the key to understanding why implants fail. And I told you I wasn't going to really teach you anything new. And I think if I said to everyone, hey, the implant body is rigid, you would tell me, yeah, I know that. But knowing something and really applying it to what we do are two different things. And I think, if you really think about your implant dentistry, we don't always restore anticipating that the implant is rigid. We kind of just restore for teeth. And so normally when an implant fails, the primary cause, if you really think about it, is that the implant is rigid. And so the reason that's important is because the implant body itself is the strongest part of the system. And implant restoration can fail in a number of different ways, but it will not fail at the implant. So, knowing that, you can kind of work through the problem and at least design that next restoration to be successful. So you're going to see this a lot tonight, because I really want you, I want coming out of this for you to say, hey, implants are rigid, and I really have to account for that. So kind of hit on that a little bit, but talking about that concept and the implant being rigid, if we want to base our restoration, base our solution, starting with the implant is rigid. So let's talk about the two basic causes of implant restorative failures. And the first one is occlusal forces. So there's a lot of different types and angles of occlusal forces. Teeth get hit in a lot of different ways, but you really can kind of break it down into three basic forces. So you have vertical forces, lateral forces, and then even though it's a vertical force, I would put cantilever forces into their own topic or their own group. So a vertical force is really just straight down compression on the implant. Most failures we're going to talk about are really due to more occlusion than maybe just biting into, something. And we all see that in regular dentistry, right? The patient goes, I was just biting on a piece of bread. Well, the restoration failed a long time ago. It's just that in that particular moment, they were biting on bread, and that's when it broke. But generally, the causes of the failures are going to revolve around vertical forces, or I should say forces. And so one of them is vertical forces, and it's just that straight down compression on the implant. Then you have lateral forces, which are, your excursive forces. So your buccal and lingual interferences, the forces that happen in movement, and some of them really can't be prevented. So, Tonight, I'm really going to keep the conversation narrow, and I'm going to talk about molar teeth. But if you think but my point, the reason I'm keeping it narrow is for time. But I feel like if you really understand the concepts of why molar teeth fail, it really starts to apply in all levels of implant dentistry. So we could spend a week or easily 2 days talking about all the failures in implant restorative dentistry. But if we keep the conversation kind of narrow, then I feel like with this group, we can have a good handle on the why behind the basic failures. And then it's easy to take that knowledge and expand it. But the reason I inserted that at lateral forces is because if you think about anterior teeth, they're going to have lateral forces that you can't avoid. It's just a matter of how do we accommodate for those. And then the last force is the cantilever force. And even though it's a vertical force, I put it in its own class because as restorative dentists, I would say this is the hardest implant restoration that we deal with. And I don't particularly blame anyone for this, because while we always want to try to, quote, place the implant where the restoration is going to be in the ideal place, it doesn't always happen that way. And the solution is not always to just take the implant out and put a new one in. As restorative dentists, we have to be able to work with it and come up with the best solution that we can. But the cantilever forces are significant and probably some of the most difficult ones to deal with. So there's really two basic causes for restorative failures. And the second one, sorry, I got a little ahead of myself, is delivery errors. So the forces are one cause, but then we can also have delivery errors. And under torquing is really the one that you'll see the most. And I think understanding torquing is really, as an implant restorative dentist, we have to have a really good handle on it. And I think that it's actually kind of misunderstood, especially in the early stages of placing implant restorations. Really, if you think about torquing, what are we trying to do when we torque an implant down? Well, we're trying to pull that implant into the fixture housing. So if we've got a hex, we're trying to pull that implant into the hex and create a cold weld. I was in a conversation recently and was helping with a patient that, we took the screws out trying to take the abutments off, and the abutments wouldn't come off. And that's because they were cold welded, so they had been torqued properly. And so there was a weld to the tooth. And so that cold weld had to be broken to get them off. But torquing is just really the process of pulling that implant onto pulling the restoration onto the implant. A lot of things can create improper torque. So if we don't have the correct driver fitting, if there's, restoratively sometimes, because, in the lab, they're not torquing the restoration. If you get a deflection in the access hole, that can cause the driver to get off center with the screw, and it can create a difficult situation to torque. And sometimes you have to go in and open up that access hole to create more space for the driver so you get better direct access to the screw. But if you're ever torquing, really, if you think about good torquing, you should be able to screw it down all the way, hand tighten, and then the process of torquing should only be about one rotation of the wrench. I think of, a lot of times you'll see people or not see them, but you may have had a situation where you're almost screwing the restoration in with the torque wrench. Well, you probably have, things occurring with the restoration, like contacts that are too tight if you're doing screw retain, or you're getting deflection of the abutment, and you're not actually torquing the implant into place. You're just kind of pulling it down, but there's enough deflection there that you're not getting a true torque. So if you truly got your restoration fitted well, the torquing is actually very fast and very simple. It's just no more than a turn or two of the wrench, and you're quickly adding that torque to the screw, and you're done. The other type of screw failure that we'll see, or actual, failure, is chronic screw fatigue. So that would be a situation, and like I just mentioned, you can have that with screw retain restorations, where if you have contacts that are too tight and you're really deflecting the restoration and you're forcing it down, but most of the time it can come from bony interferences. It can come from, tissue that's too tight, but you don't get a true fit of the restoration. And especially if there's bone impingement and you'll know bone impingement or this type of force on that screw when you start to hear almost like a wrenching sound. And if you've done enough implants, you probably screwed them in before and almost heard the squeaking kind of sound. And that's actually forcing the implant through some type of obstruction. And when you do that, it creates force on that screw. And it may not show up initially, but over time, that deflection is going to put pressure, lateral force on that screw. And that can contribute long-term to a screw fracture. So you want those restorations when we're putting them on to fit passively and really go down on the tooth and torque down quickly. We talked about the causes, but there's two types of implant restorative failures. I classify them as material failures. Those would be the porcelain, mainly the porcelain. And then there's the retention failure, which has to do with the screw, the cement, screw fractures, things of those natures. So let's talk initially about material failures, and let's talk a little bit about the first one being the broken occlusal porcelain or the split crown. We've all had it happen. I mean, you get a restoration back, and I mean, you think it looks nice, come back within a year, and it just breaks, it splits in half. So, what are the causes of an implant crown just splitting or breaking? The porcelain, if you did a PFM, the porcelain breaking off the top of the metal. That's because the implant body is rigid. I'm always going to go back to that because the way that you solve this is really understanding that your implant body is rigid. It does not act, the implant doesn't act like teeth. It doesn't have a PDL. It doesn't have any give, and there's nothing beyond that implant that really moves. The bone doesn't do anything. It's just rigid. The teeth and bone have some flex, have some give by design, but we can't really copy that with implants. So we have to always be aware that implant body is rigid. Reason number two, inadequate porcelain thickness. So just like a crown, if the porcelain is too thin, especially if you get into high load areas, you can have that fracture. You can have the same thing happen, but when you attribute it to when you combine that with the implant being rigid, we have to be particularly careful of our material thicknesses over our implants. And then heavy vertical forces. So most of the time, when you get fracturing of porcelain onto occlusal, if you're using a two-phase type material like a PFM or PFZ, or you get a split crown right down the middle, it's going to be really the heavy vertical forces right onto the implant, and the material is just too thin. Pretty easy solution here. We're starting with an easy one. But what are the solutions? So you can shorten that abutment to achieve your 2 millimeters of clearance. You can either do that mechanically. If you don't like the abutment for other reasons, you can do it, with a new abutment. But shortening the abutment to get the clearance that you need. You can switch to a single phase type of restoration, especially with patients who come in with older crowns. You'll see, porcelain broken off of the metal. The metal underneath. Sometimes I get a loss of word in these presentations. So if we were chatting casually, I'd ask somebody to help me with that. The coping. So switching to a single phase material is a good solution. This is where we get into the implant being rigid. So dispersing more occlusal load to adjacent teeth, lighten the occlusion. Honestly, when I first started restoring implants, this is one I didn't understand greatly. I wanted my implants to actually work with the teeth. So I wanted them in occlusion, just like the other teeth, darn what anybody else says. I want my crowns to function. What I didn't account for was that the teeth around that implant are giving. So we don't lighten the occlusion for the implant itself, is because when people squeeze down, they compress the teeth around it. So you want a lighter occlusion so that when they're clenching, grinding, squeezing their teeth, the teeth around the implant are compressing down, and now the implant comes into load. And so now you've got an equal distribution of force. That really comes in the anterior crowns when you see incisal edges fractured off of implants, if you go and look at your excursive forces with, with occlusal paper, a lot of times you'll find that the excursion forces are equal on all the teeth when they really should be lighter on that implant crown. Why? Because when that patient pushes their teeth forward, the teeth around that implant give forward, but the implant goes nowhere. So lightening that occlusion is one of the key concepts to preventing these types of failures.
Dr. Leonard,
Yes.
I'm sorry, we have a question that's come
Okay.
in.
Already.
What is
Okay.
what is the ideal occlusal scheme for screw retained implant crowns? I usually tell the lab light centric contacts and no excursive. Would you
Yeah.
agree?
I would agree with that, and that'll come into play in just a minute when we talk about the other types of failures. Um, I would try to avoid that where you can. Obviously, in some situations we can't, and that's where, when we get into this, I'll make some of those statements about sometimes we can't really program this stuff out of our restorations. Like we can't take a canine out of basically excursive interferences because it is the excursive interference. So we have to plan materials that account for that. I would say if you're going to have particular load on a crown, on an implant crown, I would try to stay away from two-phase materials because that's when you're going to see a lot of separation. So, making that decision of when to use it these days, when to use a PFZ versus zirconia is generally a cosmetic decision. And so when you make that decision, you got to really pay attention to those excursive forces. But if you can avoid them, it's typically going to be for the best. But you definitely want that 2 millimeter thickness, especially as you get more posterior to handle the compressive kind of vertical forces that those teeth are under all the time. I hope that helps. Recontour the opposite if possible. Eliminate deep, sharp grooves. That's a kind of an old basic concept in restorative dentistry, but when you have restorations under load, especially in the posterior, they may look pretty, but dark, deep grooves kind of are the endpoint for forces. So they kind of collect forces, and that's where things can fracture. And I threw this one in for fun, but use full metal. I've done these a few times. We're really on second molars. Actually, it isn't even for fun. I had a case last year I really couldn't solve. The patient was kind of highly cosmetic, and it took me a long time. And I finally convinced her to go to a full metal type of crown on a second molar, and I never had a problem after that. So if zirconia won't do it, a lot of times a full metal crown will where you can. So let's talk about buccal and lingual fractures, and this will probably also come into play with that question. What are the causes? Well, the implant body is rigid. So forces on an implant are going to react a lot differently, and they're going to be a lot more traumatic. So because on the material, because there's no ability for the implant to really absorb any of that force beyond the implant. So if you have an excursive force, it's going to stop at the implant. It's not going to transfer really into bone. It's typically due to lateral forces such as excursive interference. And it goes back to, what's the occlusal design? And the general cause is thin porcelain in the cervical area. And I'm really starting to like that question because there are times when you can't avoid, excursive interferences. So what do? And that's why we have to really think about the implant being rigid and how are we going to design the restoration to accommodate that. So what are some solutions? So I try to be really fancy here. If you look at that area, here's your lateral force. But what we have to remember when we talk about buccal and lingual fractures is that force is being transferred right there. And so again, the force gets placed on the lateral. And so this is different than vertical. And now that force transfers through the restoration and ends up at the cervical area. And if you have a failure on the same side, so if it was more towards, if this force at the top is going to the buccal and you have chipping, if the failure is on the buccal, you're going to see chipping at the base of the restoration, kind of small chipping, if you think about how that restoration will tip. But if you have it transferred to the lingual, you're going to get almost a shear because of that, how that restoration is being kind of hit kind of mid cervical by the abutment. I know that's complicated, but just thinking about those forces will help you really, I would associate shearing and things like that with excursive forces myself. So what can we do? We can eliminate the excursive interferences for sure, keep them off the buccal and lingual cusp, thicken the porcelain at the cervical area. So every now and then you get a restoration back, man, it looks really thick at the bottom, at the base, but that restoration is going to be able to resist some of those forces. If you design a restoration that's going to get traumatized with lateral forces, or as we're about to get into, cantilever forces, and that material at the base of the restoration is really thin, it's going to be very susceptible to fractures. And we can utilize a custom abutment that allows for wider cervical porcelain. So a lot of times you end up with these very, very thin margin abutments. You may want to go to a kind of a abutment with a very thicker margin that allows for more restorative material. So let's talk a little bit about interproximal failures. And this goes back, might be a little bit out of order here. Again, when we talk about material failures, interproximal fractures. So we're talking about lateral, we're not out of order, I take that back. We're talking about buccal and lingual fractures. Let's talk a little bit about interproximal fractures. So these we see a lot of. Again, what causes the implant body is rigid. It goes back to being rigid. You're probably going to, at some point by this, go, man, that guy would not stop saying the implant body is rigid, because it's such an important concept in implant dentistry, but also in fixing restorations the second time, so they last much, much longer and serve the patient much better. They're typically due to unsupported restorative materials. So I'll show you a few examples here in just a second. And cantilever forces are a big cause of these. So cantilever forces are when you get off center of where the force should be directed, and we start to direct force in areas that really weren't intended by design to hold force. So for an implant, they were intended to have force, placed vertically directly onto the implant. So these are really, really nice restorations. And honestly, just because we have a restoration come back from the lab like this, it doesn't mean it's not going to work. It doesn't mean it was done badly. It doesn't mean any of these. It just means that these types of restorations, when you see them, if they failed, you can see where the potential could be. And that's that we're trying to support force in areas that aren't supported by a material that can be resistant to, fracturing. So if we had a lot of force over one of the ridges on one of these implants, you could definitely get a shear interproximally. So what can you do when you have this interproximal shear? Well, going to a single phase sturdy material is going to be more resistant to that interproximal fracture. So a lot of those fractures you generally will see in two-phase materials. What this type of restoration will do, though, if there's still a cantilever problem, is move that force somewhere else. And we'll talk about that in just a minute. But going to a single phase material when you can is very good for kind of getting rid of fractures, especially when you have separations from the core or the undercore of the crown. And another thing that works really well, especially when you need the cosmetics, is getting the abutment out and under the material to support it. So doesn't always have to be a custom abutment, but it needs to be an abutment with a wide base. I love this restoration on the left where you have that kind of metal out under the under that material that could fracture interproximally so that you can support that material. And if you look here on the right, this is a nice wide abutment that gets out from the implant. So when that material is compressed interproximally, there's going to be metal from that abutment supporting that material so that it'll have less of a tendency to fracture. And then going back to, interproximal fractures, the other cause can be cantilever forces. This implant here, not done by the dentist. It's hard to, I mean, I don't want to have too many implants that I can show that are placed badly, but this one here was not placed by where I got it from, but it was showing an implant that was placed at a wrong angle. But from a restorative standpoint, this would be a very difficult restoration because it would create a really big cantilever on this implant. And, why do these implants get placed this way? Well, when we're actually placing and doing surgery, there's always a fear of hitting the adjacent tooth. But if we get too far away from the adjacent tooth, now we start to create restorative challenges. So you will run into a lot of cantilevers in the molar area because a lot of times implants are just by safety design, there's a tendency to place them a little too far away from the adjacent tooth. The other thing that can cause a cantilever is an abutment that's too small. And this is a restoration that came back where the crown completely busted off. It was a screw retained restoration, but the crown completely busted off of the underneath abutment. And when you look at it, the rest of a stock abutment was used. And so the abutment itself really didn't have a large enough base to support the porcelain. So when the porcelain was stacked and everything was placed, there was a lot of unsupported material. It's also in a molar area. So as soon as, over time, as this tooth gets exposed to more and more force, that porcelain eventually fractures. So what are the solutions? Again, similar solutions, just a little bit different design. But if you're going to use a custom abutment and cement your restoration, you want to get your custom abutment out into the underneath the cantilevered area. So really extend it so it's supporting the porcelain, supporting, even if it's zirconia, you want to get that abutment out to support that. If you're using screw retain, trying to go with a single phase material is going to give you the best chance to protect your restoration from fracturing. So, the full zirconia restoration is getting more and more common, but even if you're using a cemented zirconia crown, getting that abutment out and underneath that restorative, that area of susceptibility is key to protecting that restoration. And then another way in another area, a solution is, and this is something where we talk about, the implant being rigid, it often gets overlooked, is moving the force over the implant. So, our labs a lot of times create these really nice restorations that look great, but when you look at them, this is a pretty common cantilever that we see. And, really kind of not thinking about this as a molar and thinking more about it as just a restoration that's sitting on a fixed, rigid implant, move that force back to the distal of the crown to the point that you can't even get a mark on the front of that crown. And that will take a lot of the force and pressure off of that cantilever area and put it over the top of the crown. So when I'm forced to restore these situations, I really reduce the amount of, I move that force back onto the implant to try to decrease any risk of breaking or shattering. Okay, so moving away from restorative failures, let's talk a little bit about retention failures. And I think hopefully for those of you who haven't done a lot of these, you're going to pick up some nice little tricks here for dealing with some of these, because these are the ones where we get into, it's easier to replace a crown first time, it's easier to replace it a second time. The third time, you start to scratch your head and wonder why it keeps breaking. And I hope I've helped you with that. But a lot of times you get into these types of failures. These are the ones that can get really, frustrating. So first one's pretty simple, but when a crown debonds, especially one that's been cemented onto an abutment, that's a failure. And and I call these retention failures, but it's a cementation failure. The other type of retention failure is screw loosening. And then the last type that you see is the screw or the hex fractures. And this is where the restorative parts just fail inside the implant and they have to be removed and the restoration has to be redone. So cementation failures, again, the implant body is rigid. So now we've created a really nice restoration that can absorb all the force. Now the force is starting to transfer through the system, making its way to the implant. And then a lot of times the cement will give away because everything else is stronger than the cement. We may need to change to a stronger cement. So I'm not opposed to myself to cementing with permanent cements. If you don't, and you find that a restoration is giving you problems, strengthening the cement can help. Adjust the occlusion as needed. So, typically debonding, separation of the cement is going to be related to occlusion. That's going to be one cause. The other cause is going to be lack of internal retention. So, at times we're trying to re-cement a crown, it keeps coming off, and we just have to find a way to create a taller abutment, or maybe go to something that's screw retained so we can get a better bond in the lab. But cement failure is a type of retention failure. So let's move on to screw loosening. So again, implant body is rigid. Like, how does that come into play with a screw loosening? Well, because if a screw was not initially torqued really well, and sometimes even when they are, if we have lateral forces, we have vertical forces. Not really vertical, but if we have cantilever forces, that restoration is having pressure put on a lot of different directions, and over time that screw can start to back out to the point that it just will eventually come loose. So what causes it? It can be poor initial torque. So, a lot of restorations we didn't put in ourselves. We have no idea what the situation is when they were put on. A lot of these restorations, when you actually go in there, you'll find that the screw is stripped. And that just means that, if we're torquing correctly, we would not strip a screw when we deliver the crown. So if it was stripped at delivery, but it was kind of tight enough to work, that means that the restoration wasn't torqued in properly. And then cantilever and lateral forces can cause it as well. We've talked about how to set the restoration up better, but sometimes the actual restoration doesn't fail. The screw itself and that retention complex will start to fail. Screw loosening is implant failing or just a loose screw. Obviously, you can take an x-ray, but one trick that I like to really use for determining is if you see enough of these, a loose screw will wobble. And so you'll almost feel it clicking against the hard implant. And so it'll almost have like this kind of loose wobble from the top. A failed implant is going to tip. And so when you can even kind of grab the bone in the area, buccal and lingual of the implant and push it, and you'll feel give in the bone. So just remember when you're trying to make a quick assessment that a failed implant is going to tip. And that's never really a great day, but if you go in there quickly and you see the top of that crown wobbling, you generally know the implant's in good shape. So how do we access a loose screw? We see a lot of cemented crowns. Obviously, we'd love to see them all come back with an access hole and just clean it out and go. But sometimes they're cemented. And so how do you get to these? Well, this is a trick I learned from a friend of mine a few years back. Really makes a lot of logical sense, but just take your x-ray and take the time to take something straight and put it right down the center of the x-ray. And that will tell you a reference basically on the cusp area, like where you need to try to go in to find the screw. And that will give you an idea. Is it off-centered? Is it in the center of the crown? Is it off-centered to the distal? Is it to the buccal? Or not to the buccal, but to the mesial? And that will begin to tell you where to start your access. And when you figure that out, you just want to go in, kind of initially punch through the enamel and start to expand back. And as you start to open up the material, they're not always easy, but if you do enough of them and you give enough a try, you're going to get to where you can feel when you actually punch through the material, just as if you were cutting a crown off a tooth, and then you can start to open that up and look for the screw access. As long as you are staying within about a millimeter or two of the surrounding kind of circumference of porcelain, you're probably in the safe zone to really take the crown apart, tighten it back up, do whatever you need to do. If you start violating that area, you're probably getting to the point of needing a new crown. Again, it goes back to what I said in the beginning. patients have a little bit of a different perspective when we're helping them in these situations. They thought when they came in that they were going to lose their implant, right? I mean, my crown's loose, obviously implant and everything's failed. Now I'm the dentist telling me your implant's fine, but the restoration has a problem. You get a little, if I'm going to try to save the restoration for you, I don't know the condition of the restoration. I don't even know if I'm going to be able to save it. But if I can, it's a great day for all of us. There are times you go in and try to do this, the way the crown was placed, the way the abutment is, you just can't save the crown and you just have to do a new crown for the patient. But you can save these from time to time. While we're on that, let's talk a little bit about removing strip screws. I put it in with screw loosening, but honestly, most of the time when you need this tool, these are going to be secured and you're accessing for other reasons. But I love the screw removal tool. If you haven't seen it, it's a reverse threaded instrument. I used to do other things. I used to go in and drill slots and take a little screwdriver and try to go in and notch the screw. And I've switched over to this screw removal tool, and I've never had an issue taking out a torque screw with the screw removal tool. So you can email me. I'll give you my email at the end if you want a specific company, but a lot of different companies will make these, but they're just reverse threaded. They fit into a torque wrench, and you basically go in a counterclockwise direction. It'll engage the head of the screw, and it'll even take out a torque screw. And they work great. If you're a restorative dentist and you're replacing implants, you should have one of these in your kit, because even in the course of you placing a restoration, your screw can strip and you need to be able to get it out and get a new screw, and you want to have one of these available to take those strip screws out. It's a great tool.
Thank you,
Yes.
Dr. Leonard. We have another question.
Okay.
What is the proper torque for torquing an abutment and screw retain crown?
So it's going to vary. The amount of torque is a little bit implant driven, but I would say that between 30 and 35, you're typically safe. If you don't get to that, and there's really, you've checked the torque on it, but you definitely want to get to torque. You don't want to over torque, but you want to get to torque. I mean, there are some implants out there. There's so many different brands. Some will say 25, some say 20, but when we're talking about single implant restorations, I would say, 35 is a typical number. If I'm in doubt, I go to 35. I've never broken anything going to 35. I guess if you had a all ceramic abutment, you might want to torque a little bit less in the anterior, but in the posterior, if you're dealing with metal restorations, I've never had an issue torquing to 35 Newton centimeters. But some implants, they will tell you to go to 30. Is a pretty good safe range.
Thank you. And we have another one. Do you have
Okay.
any hints for accessing loose abutments on incisors where you're unsure if that access comes out of the facial or the lingual direction?
Nope. Nope. You get a loosen on the front. I would try to go in from the lingual as best I can, but most of those are going to be, if it was accessed from the lingual, it'd probably be screw retained anyway. The only thing you can do there is try to access it, but it's hard to get enough information. A loose anterior crown is usually not going to be easy to remove. So I would try to go in from the lingual and take a look, but I wouldn't have high hopes myself if I were doing that. Another question just popped up. Let me continue just a little bit, Jessica. Give me a slide or two and we'll let a few more pile up. So always remove that restoration when they're wobbled. Never go in and just torque one straight down. I used to do this. It took me a few tries to learn this, but you need to take the restoration off and examine it, because fractured hexes are a thing. And once that hex fractures, you might be able to tighten it back down in the moment because of the contacts. But if that hex is fractured, it won't be long before it's loose again. So I always, if I go in and I'm tightening an implant crown back down, I take it off, I examine it, make sure it's in good condition. If I can pop the screw out, I will take a look at it. I just want to make sure the parts are in good shape. But my biggest reason for taking them off is to examine the fractured hex. Because even though the screw is broken on this one, you can get hex fractures, which are typically going to be bent screws too. And if that happens, if the hex is fractured, the restoration is done for. It has to be redone. So let's talk about removing the screw fracture. You know, the screw is kind of the last line of defense, right? If everything starts to add up, we've got a good restoration, got a great abutment, everything's built right, that screw fracture is really the last line of defense. Technically, the last line of defense is the collar of the implant, but if we get a collar fracture, that no longer is a restorative problem, that becomes a surgical problem. But again, why do we have screw fragments, screw fractures? The implant body is rigid. That it just goes back to that. There's nowhere for that force to go. It's going into the screw. If the screw can't overcome the force, it's going to fracture, bend. Bad things are going to happen. It can happen with a well-designed restoration, except that there's forces in bad directions that even if you try to do your very best, you can have a screw fracture. And it generally is done to strong cantilever or lateral forces. So if I have a restoration that actually ends up with a screw fracture, I've been in situations where I think I had a restoration one time that the screw fractured, I think at least 2 times, if not 3. By the second time, I'm like, just taking this thing completely out of occlusion. I'm taking away as much risk as I can. And that's what we had to do. I never had to do it, but on a cantilever, I've considered placing a rest on the adjacent tooth. I don't know that it would help a lot, but it's just a thought. But I've never had to do it. And the implant can be damaged. So, you know, if you see this red area, there's a risk that this implant here is damaged and you need to inspect it carefully. But once that screw fractures, there's going to be a pretty abrupt force on the collar of the implant. And so inspect the implant really, really well and make sure that you didn't get a collar fracture as well on the implant. Like I said, the implant body is rigid, but the collar is thinner and you can get a break in those areas. So hopefully you don't, but sometimes you do. So here's a key concept. And sometimes you see a screw fragment down in an implant, kind of like, oh boy, I don't want to touch that. This could be awful. I actually coached someone through this the other day. And, you know, I told them it's going to be tedious, but you can get it. And they did. You ended up getting it out. And the reason is that, remember, torque is created by pulling on the implant. So when we pull that restoration down, we're getting a cold weld, we're pulling it onto the implant. So we've got all these forces, these kind of pulling forces working against the implant, and that's what creates the cold weld. But when that screw fragment fractures, you don't have torque anymore. So now that fragment's not under any opposing force, it's just sitting in the implant. And you'll find, I mean, I've probably removed 15 or 20 of these, that fragment is typically going to be really loose. And there's a time and a place where it isn't. And, you know, if you get into these further, you can attempt to try to remove these, but you're going to find, if you have the right tools, that most of these screw fragments are very loose. And so once you can get a hold of them, these screw fragments will come out. So here's the tool that I use. Really good friend of mine a few years back put me onto this tool. And I thought it was part of a secret society when I heard about it, but it actually is out there, easy to order. But the screw fragment, the screw fork, fragment fork is just, you really have to have this in your office. It's a 1.4 millimeters, the one I like. I think they make a 1.2 or 1.0. It gets to be a little bit small. I like kind of the bigger one. The smaller ones are for different situations. But if you have this 1.4, you're gonna be able to handle most fragment force. I know there's a lot of ways out there, a lot of kits that can be ordered, a lot of tricks. I mean, running round burr to the implant. But if you're just trying to take a few out from time to time when they're loose, you're gonna love this fragment fork. And it's these little forks are kind of designed to grab the implant, the top of that metal, when you turn it counterclockwise. They won't always grab into the material, dig into the material, but a lot of times those forks will find kind of a rough surface and grip the screw. So sometimes you kind of move it around until you find something in that fragment that's a little bit uneven, and then the fork will grab that and you can start turning it. I think the first one of these I ever did took me about 15 minutes, and at first I was like, I don't even know if I'm moving this. But as I started looking, I could see that fragment get higher and higher up in the implant. So all you do is take the fork, put it down on the fragment, turn it counterclockwise, give it some push down on it a little bit to kind of engage into the fragment. Can't damage the implant with it. Nothing bad can happen, and just start trying to tease it and turn it. It's hard to get a explorer down into these, and when they're further down into the implant, you need something to go down in there and really try to find a spot to grab to. So I love using that fragment fork. And then as you're working it, you'll see that fragment get right up to the top. And then at that stage, I'll normally grab an explorer and just kind of keep teasing it, and it'll be really loose. And you'll start to get really excited because like, I almost got it. And then you realize it's a little bit longer than you thought. And so you can get in there with hemostats and take it right out. But that fragment fork will get it moving up for you in the right direction. Boy, I could have had a few extra minutes, but let me run through implant identification. Always kind of obvious, try to contact the restorative dentist. Ironically, we don't think about this, but when you get a hold of the dentist and they give you information, see if you can get the lab. The lab normally has more accurate information than the restorative dentist, because they have the parts, so a lot of times I'll reach out to the lab and I'll get better information on the case. I love the implant identification website. What implant is this is my go-to. I really like using that. And when in doubt, kind of stay towards common brands. For as much as we want to think that it's a KRS 850, whatever, it's probably a Nobel or a BioHorizons. It's shocking when implants come from other countries and you really start to research and you find out it's just a name brand implant that a lot of people use. So when you're trying to identify implants, don't be afraid to go with something that's really common. If you can get it down to the brand, you can usually reach out and get it identified and get it figured out. What am I looking for when I'm doing implant identification? I'm not trying to pinpoint the exact implant on the site. I'm just trying to get into a range and then start looking at, at least get the opportunities narrowed down. But I'm definitely looking at the hex design, internal versus external. The collar. So is it a smooth collar or is it micro-threaded? That's a big key. And then the apex curve is one of the bigger. And is it rounded or flat? And then apex holes. So do you have any holes at the bottom or no holes at the bottom? So those are generally the four things I'm really looking at for implant identification. They can normally get me to a close enough brand. If you get it down to like a Zimmer and it's a Zimmer hex, you're done. Use a Zimmer hex. You're in good shape. So, and then there's companies, I like working with Preet. They, they're kind of a non-OEM. OEM, if you don't know, is original equipment manufacturer. So it's the brand specific abutments, but there are companies out there that make non-OEM parts that can be fitted back, to other implants when you're trying to rescue a case. They're kind of nice to work with because they have a lot of different options for you to restore that case. And then always work in your lab. I'm shocked how many times I think I have the solution. I get on the lab, I'm like, well, have you ever thought about this? I'm like, no, I had no idea that existed. But I love getting the lab involved with these more difficult cases. A few last tips. I can't expand on these because I told you I was going to keep it very narrow, but a few things to think about. Screw retained implant bridges can be tricky. You're trying to line up two hexes and two contacts. A lot of times those hexes have to be reduced to make everything align, and that can affect a little bit of the retention. So when you're doing screw retained implant bridges, your implants need to be aligned really, really well to be most successful. Tall locators can cause acrylic fractures. Same thing, implants are rigid. So locators are rigid, the denture's not. Movement after picking up locators is usually a result of patient biting for themselves. We could debate this a little, I'm sure. I'm sure there's ways, but if you're picking up your own locators and you have a wobble after it's done, I like to hold mine in myself so that I hold it flush to the tissue. On all on X's, be aware of rigid materials on the lower arch. I've had a couple of lower all on X restorations fracture, not really on the top, usually on the lower. I can't say definitely, but I don't know if it's due to flex of the mandible. I mean, I'm not scientific enough to debate that, but I have switched to more non-rigid materials away from zirconia and some of your acetal materials and solve that situation. And then there's a sneaky way to do a cantilever on all on X's. So as long as your cantilever isn't activated, you can extend a little further on the upper arch. I worked with a lab one time and they weren't going to make the upper because the cantilever was too long for their requirement. I'm like, well, I'm only going to go back to the premolar on the bottom, to the premolar. So we don't actually have a cantilever. It just appears to be a cantilever, but they're never going to use that cantilever. So we're able to get the patient a broad smile without activating the cantilever on the upper restoration.